Welcome to the deep dive. Today, we are really tackling a massive topic, the anatomy and pathology of peripheral nerve injuries.
It's a big one.
Yeah, and we're not just, skimming the surface here. Our mission today is to really understand how a nerve responds to trauma, like everything from a simple stretch to complete severance at the level you'd expect from an elite professional.
Absolutely. The source material we're drawing from is incredibly detailed. Think foundational anatomical texts, surgical pathology reports. We're going to unpack the whole spectrum of nerve injury and the biological devastation that follows an injury, and also the very complex, very time-sensitive process of potential recovery.
Okay, let's unpack this then. We are focusing hard on what happens inside that nerve trunk when it gets injured. Maybe by a dislocation, maybe a bullet gets close, or even just prolonged compression.
Right.
And crucially, why recovery is often so unpredictable. What makes the difference?
So first off, we need to remember what a nerve trunk actually is. It's not just one wire.
Right. It's more like a cable, isn't it?
Exactly. A complex cable. Thousands, literally thousands of individual axons bundled together inside these things called fascicles.
And that complexity, that structure, must be why injuries are rarely straightforward.
It's precisely why. Think about a major joint dislocation, like you mentioned, the shoulder humeral head popping out, violently stretching the brachial plexus nerves nearby.
Ouch.
Yeah, the impact isn't uniform at all. Some axons might just get stretched momentarily and stay intact. Others might suffer a physiological block, like a temporary short circuit, but they recover pretty quickly.
But others aren't so lucky.
No, a critical number might actually rupture completely, and that rupture kicks off degeneration, Wallerian degeneration, distal to the injury site. That's a whole different ballgame.
And you're saying this damage varies not just along the nerve's length, but also across its width, like side to side.
Absolutely. You could have severe tearing on the outer fascicles, the ones closest to the trauma, but maybe deeper inside the trunk. The axons only experienced a mild stretch or a conduction block. It's heterogeneous.
Okay, so this huge range of possible damage, it obviously needed some way to classify it, right, to talk about it systematically.
Precisely. And that brings us to the foundational classification systems. We really have to start with Seddon. Back in 1943, he gave us three critical terms.
The big three: neurapraxia, axonotmesis, and neurotmesis. Can you just quickly remind us of the prognosis tied to each one?
Sure. Neurapraxia is essentially a conduction block. Think of it like a temporary electrical fault. There's no lasting structural damage to the axon itself.
So best case scenario.
By far. Recovery is usually spontaneous, often within days or weeks. Then you have axonotmesis.
Yeah.
Here, the axon itself has ruptured. It's a degenerative lesion.
Okay, so worse.
Definitely worse. But crucially, the internal connective tissue scaffolding, the endoneurial tube around the axon, is still intact. That's key.
Why is that so important?
Because that intact tube acts like a guide. It gives the regenerating axon a clear path to follow back to its target. So the prognosis is still considered favorable, assuming the cause is dealt with.
And the last one, neuromesis.
That's the most severe. It's also a degenerative lesion, but here everything is disrupted. The axon, the basal lamina tube, the surrounding connective tissues, the whole architecture is gone.
So no guiding tube, chaos ensues.
Total chaos. The prognosis is unfavorable for spontaneous recovery. Surgery is almost always needed.
That distinction seems absolutely critical, whether that supporting tissue, that scaffolding, is intact or not.
It's the fundamental difference. But, Seddon's three terms, while groundbreaking, didn't quite capture all the nuances, especially regarding how much of that supporting connective tissue was damaged.
So it needed more detail.
Exactly. You got different layers, right? The endoneurium around each axon, the perineurium bundling fascicles together, and the tough outer sheath, the epineurium. Damage could affect some layers, but not others.
And that's where Sunderland came in.
Yes, Sunderland. In 1951, he recognized this limitation and expanded Seddon's system into 5 degrees of injury.
Okay, so how did he break it down? Did he just subdivide Seddon's categories?
Pretty much. Sunderland's first degree is pure neurapraxia conduction block only.
Same as Seddon's neurapraxia.
Right. Second degree is axonotmesis, but only the axon is severed. The endoneurium, that immediate tube, is still intact. That's Seddon's axonotmesis.
Okay.
Then third, fourth, and fifth degrees represent progressively worse damage to the connective tissues. Third degree means the endoneurium is disrupted. Fourth degree means the perineurium around the fascicle is gone too.
And fifth degree?
Fifth degree is complete transection of the entire nerve trunk. That's equivalent to Seddon's neurotmesis. All layers are severed. This level of detail matters because, as we said, the integrity of those endoneurial tubes is just paramount for guiding successful regrowth.
And I think the sources mentioned McKinnon and Dellon added a sixth category later on.
They did in 1988. The sixth degree basically acknowledges the reality we discussed earlier that injuries are often mixed. A single nerve cross-section might show areas of neurapraxia, areas of axonotmesis, maybe even some neurotmesis all at the same time.
Right, reflecting that real-world messiness.
Exactly. But if we boil all these classifications down, Seddon, Sunderland, the sixth degree, what's the single most critical clinical test, the thing you check immediately, that tells you if you're dealing with a potentially reversible block versus a definite axon rupture?
It has to be checking the electrical signal, right, downstream from the injury.
Bingo. It's the absolute core physiological marker. In neurapraxia, even though the signal is blocked at the injury site, if you stimulate the nerve distal to that site, it still conducts. The wire is intact downstream.
Okay, makes sense.
But in axonotmesis or neurotmesis, because the axon itself has been physically broken, there is absolutely no conduction in that distal segment. Stimulate it all you want, nothing gets through. Wallerian degeneration has started.
Wow, so that test, checking distal conduction, is like an immediate red flag if it disappears early on.
It's a huge warning sign. It often signals that the lesion is actively deepening, maybe due to ongoing pressure causing critical ischemia, lack of blood flow. That loss of distal conduction confirms you've gone from a temporary physiological hiccup to actual physical anatomical rupture.
And when doctors use the term neurotmesis in a clinical setting, what does that usually imply in practice?
In practice, it almost always means the entire nerve trunk has been severed, clean cut, or maybe torn apart. All the internal bits, fascicles, perineurium, epineurium, they're all interrupted. There's usually a physical gap between the two nerve ends, the proximal and distal stumps.
Which obviously means spontaneous reconnection is impossible.
Impossible. It screams surgical intervention needed.
Okay, let's park the severe stuff for a moment and go back to that first-degree injury, neurapraxia, the reversible conduction block. Even though it's temporary, you mentioned it tells us a lot about how different nerve fibers react differently to stress. What are the hallmarks?
Yeah, the clinical picture is very specific, almost diagnostic. First, the paralysis, the loss of muscle power, is always much worse than the loss of sensation. Motor fibers seem more sensitive to this block.
Okay, movement goes before feeling.
Generally, yes. Second, within the sensory system itself, there's a hierarchy. The big, fast-conducting fibers are hit hardest. These are the ones carrying proprioception, your sense of joint position, where your limb is in space, and also deep pressure sense.
So you lose the ability to move properly and know where your arm is before you lose the feeling of, say, a light touch on the skin.
Exactly. Those light touch fibers, often smaller, are less affected. And even more resilient are the sympathetic nerves.
The autonomic ones.
Yeah.
Controlling blood vessels, sweat glands, that kind of thing.
Yep. They are predominantly unmyelinated or very tiny myelinated fibers, and they are the least affected in a pure neurapraxia. So this distinct pattern motor function drops, big sensory fibers drop, but light touch and autonomic function are largely spared. That's the signature of a conduction block.
And what's actually causing that block?
Often it's temporary ischemia, lack of oxygen, usually from prolonged compression. Falling asleep with your arm over a chair, Saturday night palsy, even crossing your legs too long. The pressure cuts off the blood supply just enough.
Right. And this whole idea of selective vulnerability to ischemia, it was really pinned down by a classic experiment, wasn't it? Lewis and colleagues back in 1931.
Oh, yeah. The Lewis cuff experiment is absolutely foundational. Required reading. They inflated a blood pressure cuff on the arm high enough to completely stop circulation and then meticulously recorded the order in which functions failed.
And what did they find? What went first?
First to go was superficial sensibility light touch, basically. Then, very quickly afterwards, they observed a graduated loss of muscle power. Weakness crept in progressively.
So confirming that motor and those large sensory fibers are the most vulnerable to oxygen deprivation or pressure?
Precisely. Then came pain perception. The initial sharp, fast pain response disappeared soon after light touch, and this is fascinating, the delayed pain response.
The dull, aching C-fiber pain.
Exactly. That slow, burning pain carried by the smallest unmyelinated fibers. It was incredibly resilient. They could still detect it even after 40 minutes of total ischemia. 40 minutes.
Wow, that is stark evidence for selective vulnerability based on fiber size and myelination. The big guys go down first.
Absolutely. Large myelinated axons motor, proprioception, fast pain, touch. They're the most metabolically demanding or pressure sensitive. The tiny unmyelinated ones, like slow pain and the autonomic fibers, they just kept going. Palamotor function, goosebumps, vasomotor function, blood vessel control, scarcely affected.
And what about recovery, when they let the cuff down?
Recovery was remarkably fast. As soon as blood flow returned, all the functions came back online within minutes, though often accompanied by that really unpleasant pins and needles sensation dysesthesia as the nerves sputtered back to life.
Yeah, we've all felt that. The sources also mention observations from surgery using tourniquet cuffs. That gives a sort of clinical timeline for how long different parts can tolerate ischemia.
It does, and it's critical for surgeons managing limbs under tourniquet. What they observe is that the muscle response you get from stimulating the nerve starts to diminish and then disappears after about 30 minutes of ischemia.
So the connection point fails first, the neuromuscular junction.
That's right. The synapse, the NMJ, seems to be the weak link in the chain under these conditions. It fails after about half an hour. But interestingly, conduction within the nerve trunk itself, proximal to the NMJ, keeps going for roughly another 30 minutes after the NMJ has failed.
So the nerve wire itself is tougher than the connection point.
It seems so. And then, even after nerve conduction itself fails, so around 60 minutes total, if you bypass the nerve and stimulate the muscle directly with an electrode,
It can still contract.
it can still twitch
Yeah.
for up to about 2 hours after the nerve conduction is lost. Only after that point does the loss of direct muscle excitability signal that the muscle fibers themselves are starting to die irreversibly.
That's a really important timeline.
Yeah.
NMJ fails around 30 mins, nerve conduction around 60 mins, and direct muscle viability up to maybe 120 mins. That dictates the urgency for reperfusion in things like compartment syndrome.
Absolutely. Now, that's acute, rapid ischemia. What about slowly progressing ischemia? This isn't someone clamping a cuff on. This is pressure building up over hours or days. Think of a big hematoma expanding after trauma, or maybe an aneurysm slowly pressing on a nerve, or bleeding into a tight fascial compartment, common in war wounds or crush injuries.
Does the pattern of loss change when it's slow like that?
It does slightly. Because the pressure builds gradually and is sustained, the larger fibers, being less resilient long-term, might actually die off relatively early. So you can get early and quite profound autonomic paralysis, loss of sweating, changes in blood flow, and significant loss of muscle power.
Okay, so motor and autonomic go early. What's different?
The key difference clinically is that often deep pressure sense and some joint position sense manage to persist for longer. The symptoms develop more insidiously over hours or days. But the good news is, if you can find and relieve the cause, drain the hematoma, decompress the compartment, recovery can be remarkably rapid and sometimes quite dramatic.
Okay, so far we've mostly talked about ischemia, lack of oxygen.
Yeah.
But there's another type of prolonged conduction block that isn't really about oxygen, right? It's more mechanical and involves demyelination.
That's right. This is a block that can last for weeks or even months, but it's still technically neurapraxia because the axon underneath remains intact. The primary mechanism here isn't anoxia, it's mechanical deformation.
And how does that work? What's the mechanism?
The key work here was done by Ochoa and colleagues back in 1972. They showed that severe prolonged pressure doesn't necessarily crush the axon, but it can mechanically distort the myelin sheath, specifically at the nodes of Ranvier.
Those little gaps in the myelin where the signal jumps?
Exactly. What happens is a kind of slippage of the myelin layers right where they terminate next to the node, the perinodal myelin. This physical displacement, this slippage, effectively messes up the structure of the node.
How does that block the signal?
The node needs to be precisely exposed for the electrical current to regenerate and jump. If the myelin slips and partially covers it or distorts the ion channel arrangement, it disrupts that saltatory conduction. The signal just stops there. And critically, this deformation tends to be worst right under the edges of whatever is causing the compression where the pressure gradient is steepest.
Creating a very focal point of blockage.
Precisely. And this focal demyelination due to mechanical slippage is thought to be the explanation for the kind of conduction block you see in, for example, hourglass constrictions of nerve fascicles, where they get pinched by a tight band of scar tissue or squeezed against a bony prominence.
And the axon underneath is okay.
The axon itself is intact. That's why the block, although potentially lasting months or even years if the pressure isn't relieved, is still reversible. If you surgically remove that external irritant, cut the fibrous band, smooth the bone, the myelin can remold itself, the node structure recovers, and function can return surprisingly quickly.
Even after years of symptoms.
Even after years in some cases. It highlights that the underlying axon was just waiting for the block to be cleared.
One last point on neurapraxia. The sources mention something different happens with blast injuries, modern warfare-type injuries.
Yeah, that's an interesting observation. While the classical neurapraxia from stretch or simple compression hits the large myelinated fibers hardest,
Motor and proprioception first.
right, modern blast injuries involving a high-pressure shock wave passing through the tissues sometimes show a different pattern. In those cases, it seems the smallest fibers can be the most vulnerable.
Huh. Why would that be?
The mechanism isn't fully clear. It might be related to different biomechanical properties. Maybe the shock wave causes more shearing stress on the smaller, less structurally supported fibers, or perhaps there's a different metabolic vulnerability to that kind of rapid pressure change. It suggests the type of trauma really matters for which fibers are affected first.
Okay, let's move across that critical line now into the injuries where the axon actually ruptures. Axonotmesis and neurobiomesis. We said the key difference between them is the state of the connective tissue scaffolding.
Absolutely fundamental. That structural integrity dictates the potential for spontaneous recovery. Let's revisit axonotmesis. The axon is broken, yes, degeneration follows, but the crucial thing is that the tube of Schwann cell basal laminar.
The insulation sheath made by the Schwann cells.
Well, more like the outer casing or tube they sit in, secreted by them. That tube remains intact. It's like the conduit is still there, perfectly aligned.
So, if the nerve cell body sends out a new sprout from the proximal end,
That sprout has a clear, preformed pathway to follow. The basal lamina tube guides it, hopefully all the way back to the correct target muscle fiber or sensory ending in the distal stump.
makes sense. Orderly regeneration is possible.
Possible, even probable, if the cause of the injury is removed and the distance isn't too huge. But contrast that with neurotmesis. Here, it's complete destruction.
Axon gone, tube gone.
Axon gone, basal lamina tube gone, and the surrounding connective tissue sheaths, the perineurium around the fascicles, maybe even the epineurium around the whole nerve are all disrupted too. The whole architecture is just obliterated.
So no pathway for regeneration.
None whatsoever. If axon sprouts start growing from the proximal end, they hit a wall of scar tissue or just grow randomly into the surrounding tissues, there's no guidance.
Leading to
Imperfect, disorderly regeneration at best, often failing to cross the injury site altogether. Or commonly, the sprouts just form a tangled, painful mass called a traumatic neuroma right at the end of the proximal stump. Spontaneous recovery is essentially impossible.
This brings us to a really critical concept, especially clinically. The idea that a nerve lesion can actively deepen over time. An injury might start as potentially recoverable axonotmesis, but then get worse.
Yes, this is crucial for understanding why timing is everything in nerve injury management. Imagine a nerve is initially crushed or stretched hard enough to rupture axons, axonotmesis, but the connective tissue tubes are still mostly intact. Recovery could happen.
Okay.
But if the noxious agent, the thing causing the pressure, the ischemia, the strangulation isn't relieved, if it continues to act on that injured nerve,
The situation gets worse.
it gets progressively worse. The ongoing pressure, swelling, and lack of blood flow start to destroy the supporting connective tissues themselves. The basal lamina tubes break down, the perineurium gets disrupted by scar tissue, the lesion deepens from axonotmesis into full-blown neurotmesis.
And at that point, the chance for spontaneous recovery is lost.
Completely lost. The initial injury didn't destroy the scaffold, but the prolonged effect of the unrelieved trauma did. This is the anatomical justification for that critical surgical window we talk about. You have to intervene before the scaffold collapses.
And the speed at which this deepening happens, it really depends on what's causing the problem, doesn't it? The sources gave some pretty stark timelines.
They did. For something like an acute direct crush or strangulation, maybe a suture tied tightly around a nerve during surgery, or a metal plate pressing directly on it, the window is incredibly short. Recovery might only be possible if you relieve that pressure within a matter of minutes.
Minutes, not hours.
Minutes. The source material shows a devastating example where just a 48-hour delay in removing such a compression led to complete irreversible nerve destruction.
That's terrifyingly fast. What about something less direct, like compression from swelling inside a limb? Compartment syndrome again.
The window is a bit longer there, but still desperately tight. If the nerve is being choked by swelling and ischemia within a tight fascial compartment, recovery is considered probable only if you restore blood flow, by fasciotomy usually, within about 3 hours.
3 hours?
Yeah, and every hour you delay beyond that significantly decreases the chances of meaningful spontaneous recovery. The nerve tissue, the muscle tissue, it just dies. That's how you end up with devastating conditions like Volkmann's ischemic contracture, muscle replaced by dead scar tissue.
Okay, what about a nerve trapped by, say, a displaced bone fragment after a fracture or caught in a dislocated joint?
There, the timeline seems a bit more forgiving typically. Recovery is often possible if the nerve is carefully freed or extricated within a few days.
Days. Okay, that's better.
But, and this is huge, but that timeline goes out the window if external compression devices are used carelessly. If someone puts on a tight cast or applies an external fixator pin right over the area where the nerve is trapped without confirming the nerve is free and protected.
You turn days into hours or minutes again.
Exactly, you can rapidly destroy the nerve that way. Figure 1.5.6 shows a stark contrast between recovery when a nerve was freed after 3 days versus non-recovery when it was left compressed for 8 weeks.
And then there's the really slow burn stuff, like fibrosis after radiation.
Right. At the other end of the spectrum, you have things like progressing fibrosis, maybe from radiotherapy scarring or chronic inflammation around the nerve. In these cases, the nerve function might actually be retained for months, sometimes even years, before the slow strangulation finally causes it to fail completely.
So a huge range of speeds, from minutes to years. But across all these scenarios, is there one key symptom that tells you this damaging process, this deepening, is actively ongoing?
Yes. The single most important cardinal symptom is pain. Persistent, unrelenting pain at the injury site, especially if it's worsening, is a massive red flag. It strongly suggests that the noxious agent is still active, the destructive process is ongoing, and you need to intervene urgently to remove the cause and save whatever structure and function is left. Pain means the clock is ticking loudly.
Right, so once that axon is physically broken, whether it's axonotmesis or neurotmesis, the immediate consequence downstream is this process called Wallerian degeneration. WD. Tell us about that.
Wallerian degeneration is the inevitable, highly organized biological response that happens whenever an axon gets separated from its parent cell body. It's essentially a controlled demolition and cleanup operation.
And it happens in the whole distal part?
The entire distal stump, right from the point of injury all the way down to the nerve endings. And it also affects the very tip of the proximal stump, the part still attached to the cell body. All those severed axon segments, regardless of their size or function, motor, sensory, big, small, wheat, they all degenerate completely.
And this immediate total degeneration is why functional recovery, if it happens, takes so long, right?
Exactly. Because the entire downstream pathway has to be rebuilt from scratch by the regenerating axon growing from the proximal stump. That takes time, months, often years. And because the process is so complex, recovery is very often incomplete.
Now, the sources really stress that WD isn't just a local event happening out in the limb. It has major consequences back in the central nervous system, too.
Oh, absolutely. The CNS impact is huge and often overlooked. Any peripheral injury severe enough to cause WD immediately triggers significant and often long-lasting changes back in the spinal cord and even the brain.
How so? What kind of changes?
We see changes in the sensory ganglia, the dorsal root ganglia, or DRG, where the sensory cell bodies live. We see changes in the ascending sensory pathways and the descending motor pathways within the spinal cord itself. And in severe cases, especially neurotmesis, where repair might be delayed or impossible, these central effects can become permanent and irreversible.
Is this related to losing signals or factors coming back from the periphery?
Precisely. It's largely about the loss of neurotrophic factors. Healthy neurons rely on a constant supply of survival signals, these protein molecules like NGF, nerve growth factor, BDNF, CNTF, that are produced by the target tissues and transported backwards along the axon to the cell body.
Retrograde transport.
Right. When you cut the axon, you cut off that supply line. The neuronal cell body is starved of these essential survival factors. This can lead to major changes in the neuron's health, its structure, and in many cases, it leads to the death of the neuron itself, apoptosis.
And we can see this cell death clearly in experimental models, like amputation.
Yeah, amputation is basically the ultimate permanent WD model. And studies show it causes extensive loss of neurons, both sensory neurons in the DRG and motor neurons in the ventral horn of the spinal cord. You can actually measure a decrease in the number of large myelinated axons within the spinal cord tracts afterwards.
Does age matter here?
Hugely. The CNS seems much more vulnerable in the young. Neurotmesis, that complete severance in a newborn or infant, causes much faster and much greater death of sensory and motor neurons compared to the exact same injury in an adult. There's a critical age dependency for neuronal survival after injury.
But it's not all doom and gloom for the neurons that do survive the initial shock, right? They fight back.
They absolutely do. The surviving neurons launch a massive internal response. They switch on a whole suite of genes known collectively as repair-associated genes, or REs.
What do these genes do?
Their job is to basically switch the neuron's priorities.
Hmm?
Instead of focusing on transmitting signals as normal, the neuron retools itself for survival, defense, and regrowth. These RAGs trigger the production of proteins involved in things like axon sprouting, rebuilding the cytoskeleton, protecting against further damage, and initiating the growth process. Research, like from Kalenda and others in 2012, has shown this happens very rapidly, involving complex signaling pathways like the GP130 cytokine family. It's a fundamental shift to a regeneration state.
Okay, so let's look at what happens physically at the two ends of the break. First, the proximal stump, the end still connected to that surviving RAG-activated cell body. What's happening there right after injury?
Almost immediately, within hours, the cut axon ends seal themselves off, forming these little swellings called end bulbs. But then, very quickly, this end bulb transforms into something incredibly dynamic: the growth cone.
The explorer tip.
Exactly. Think of it like the neuron's hand reaching out. The growth cone extends these incredibly fine, finger-like projections called filopodia. They're packed with actin, constantly moving, sensing the chemical and physical environment around them. It also puts out broader sheets called lamellipodia that help it advance.
And it's trying to find the path forward.
Yes, and it does this by sprouting. We see two main types of sprouts appearing. You get collateral sprouts, which can actually bud off from intact nodes of Renvier, just proximal to the injury site, like little side branches. And you get terminal sprouts growing directly from the tips of the severed axons within the growth cone.
So multiple feelers going out.
Lots of them. These new axon sprouts quickly associate with Schwann cells that migrate from the proximal stump, forming these little teams called regenerating units. But all this growth effort takes a toll. The neuron diverts resources, and as a result, the overall diameter, the caliber of the axons in the proximal stump actually decreases.
And that would slow down conduction.
Yeah. Clinically, you can measure a drop in nerve conduction velocity proximal to the lesion site, reflecting this metabolic shift and structural change towards regrowth.
Okay, that's the proximal end gearing up to grow. What about the distal stump? The part that's undergoing Wallerian degeneration. It needs to prepare itself to receive those incoming sprouts, right?
Absolutely critical. The distal stump doesn't just passively decay, it undergoes a very active, highly programmed transformation over the first, say, 2 to 3 weeks post-injury. It's a sequence of events.
What happens first?
First is the breakdown. The severed axon fragments disintegrate, and the myelin sheath collapses and breaks down into oily droplets and debris. This generates a massive amount of cellular garbage that needs clearing.
Which triggers inflammation.
Exactly. This debris is highly inflammatory. It triggers increased blood flow to the area, and, crucially, it recruits specialized cleanup cells, macrophages, from the bloodstream, and also activates resident macrophages. These cells are essential phagocytes. They engulf and digest the axon and myelin debris. Efficient clearance is vital for allowing regeneration.
And while the cleanup is happening, what are the original Schwann cells doing? The ones that used to wrap the now degenerating axon.
They play an absolutely starring role. They survive the axon's death. They detach from the myelin debris. They change their shape and function. They de-differentiate, and then they start to proliferate rapidly, dividing to create many daughter cells.
And where do these daughter cells go?
They stay lined up inside the original basal lamina tube that their parent cell secreted. Remember that intact tube in axonotmesis? Even if it's damaged in neuroemesis, remnants often persist. These columns of newly proliferated Schwann cells, aligned within these tubes, or tube remnants, form structures called the bands of Bunger.
And these bands of Bunger are the target for the regenerating axons.
They are the explicit target. They form continuous cellular cords that bridge the injury gap, if possible, and fill the distal Schwann tubes, creating a living pathway for the incoming growth cones from the proximal stump.
So the Schwann cells are not just passive tubes, they're active participants.
Hugely active. They don't just provide a physical scaffold. They actively secrete a whole cocktail of molecules to encourage and guide the axons. They lay down extracellular matrix proteins like laminin, which axons love to grow on. They pump out neurotrophic factors to support the growing axon tips. They express cell surface molecules that act as guidance cues, like receptors related to netrin-1. They actively create a pro-regenerative environment.
That's amazing. And the sources mentioned something about Schwann cells maybe having different flavors like motor versus sensory.
Yeah, that's a really fascinating area of research. There's growing evidence that Schwann cells in tubes that originally supported motor axons express a different set of genes and proteins compared to Schwann cells in tubes that supported sensory axons.
What kind of proteins?
For example, studies suggest motor Schwann cells might preferentially upregulate things like osteopontin, while sensory Schwann cells might upregulate clusterin. The idea is that these molecular differences might help guide regenerating motor axons towards muscle targets and sensory axons towards skin or sensory organs.
So, trying to ensure the right connection gets made. Selective regeneration.
That's the hope. Whether this intrinsic guidance system is robust enough to ensure perfect functional matching after a severe injury, especially neurotmesis where everything is scrambled, is still a major question. But the potential is there within the biology of the Schwann cells themselves. They are orchestrating the entire distal response.
Okay, so the distal stump, led by these amazing Schwann cells, creates this perfect, welcoming environment for regrowth. But you said this state is temporary.
Critically temporary, this highly supportive, pro-regenerative environment exists mainly in the acutely denervated distal stump, say, the first few weeks to couple of months after injury.
So what happens if surgery is delayed? If the nerve isn't repaired quickly, what happens to that distal stump environment over time?
It deteriorates dramatically. This contrast between the acute and the chronically denervated stump is probably the single biggest factor explaining why delayed nerve repair often leads to poor functional outcomes.
How does it deteriorate? What changes pathologically?
As time goes by, if no axons successfully re-entered the distal stump, several negative things happen. Firstly, the structure collapses. You get progressive fibrosis scar tissue, dense collagen filling up and shrinking the endoneurial tubes. Fibroblasts proliferate massively.
And so the pathway gets blocked by scar tissue.
Blocked and narrowed, yes. Secondly, those crucial Schwann cells start atrophy and die off. Their numbers decrease significantly in a chronically denervated stump. And the myelin debris, which should have been cleared quickly, can actually persist for months, acting as a chronic inflammatory irritant and a physical barrier.
And the Schwann cells that do survive, are they still helpful?
They become much less helpful. They undergo changes that make them less receptive to any axons that might eventually arrive. They downregulate the expression of important receptors on their surface that axons need to interact with, like the C or B receptors.
Okay.
And maybe most importantly, they significantly reduce their production of those vital neurotrophic factors, the NGF, the CNTF, that support axon growth and survival. The chemical welcome mat is essentially rolled up.
So the environment shifts from being actively pro-regenerative to being, well, non-supportive or even hostile.
Exactly. It becomes a poor soil for regeneration. This progressive deterioration of the distal stump environment, the fibrosis, the Schwann cell loss, the decline in trophic support, this is the biological basis for what Limburg called the relatively narrow window of opportunity for successful surgical intervention back in 2000.
And how narrow is that window, typically?
For optimal functional recovery after a direct nerve repair, most surgeons would aim to operate within the first 3 to 6 months post-injury. That's generally considered the acute phase when the distal stump conditions are still relatively favorable. Delaying much beyond that significantly compromises the chances of achieving good functional reinnervation. The biological clock is ticking from day one.
Okay, that's the general case. And you mentioned earlier a special case, preganglionic injuries or nerve root avulsions, where the nerve root is torn right off the spinal cord. Common in bad traction injuries, like brachial plexus injuries at birth or in motorcycle accidents.
Yes, avulsion injuries present a really unique and challenging pathology.
What's the paradox you mentioned?
The paradox lies with the sensory neurons. Remember, the cell bodies for most peripheral sensory neurons are located outside the spinal cord, in the dorsal root ganglion, DRG.
Right.
When a nerve root is avulsed, the tear happens between the DRG and the spinal cord, preganglionic. This means the sensory cell body in the DRG remains connected to its peripheral axon, stretching out to the skin or muscle.
Ah, so the peripheral sensory nerve fiber stays alive.
Exactly. Because it's still connected to its cell body, that distal sensory axon doesn't undergo Wallerian degeneration. It remains intact, potentially healthy, and capable of conducting signals for a very long time. Figure 1.5.7 in the source material really illustrates this. You can see healthy-looking sensory fibers distally, long after an avulsion.
So the patient might still feel something if you stimulate the skin, even though the root is torn from the cord.
Potentially, yes, although the signal can't reach the brain. But the peripheral fiber is alive. The tragedy, however, is on the motor side.
Because the motor neuron cell bodies are inside the spinal cord.
Precisely. The motor cell bodies are in the ventral horn of the spinal cord. When the ventral root is avulsed, the motor axons are severed from their cell bodies. So they do undergo immediate Wallerian degeneration all the way out to the muscle. Same for the postganglionic autonomic efferent fibers.
So complete motor paralysis is immediate.
Immediate and permanent unless something is done. But the even bigger tragedy is what happens to those motor neuron cell bodies back in the spinal cord.
They die because they've lost connection to the periphery.
Yes. Just like we discussed with neurotrophic factors, motor neurons also rely on signals coming back from the muscles and Schwann cells they innervate. When that connection is severed by avulsion, the motor neurons are deprived of that support, and the result is catastrophic cell death within the spinal cord itself.
You said this cell death is fast.
Terrifyingly fast. Studies have shown that you can lose up to 50% half of the motor neurons in the affected spinal cord segment within just 2 weeks of a ventral root avulsion.
2 weeks. That's an incredibly urgent situation.
It absolutely is. It highlights the desperate need for swift intervention in avulsion injuries. The goal of surgery, often involving nerve transfers or sometimes direct reimplantation of the root if possible, is primarily to reestablish some kind of connection between those dying motor neurons and the peripheral nerve stump as quickly as possible.
To try and rescue them with trophic support from the periphery.
Exactly. To get those essential survival factors flowing back retrogradely to the spinal cord and hopefully halt or slow down the relentless process of motor neuron death. It's a race against time to save the central command centers.
Okay, so let's assume we've overcome the odds. Maybe through timely surgery, maybe axonotmesis allowed spontaneous growth. We've got axons physically crossing the injury site and reaching the distal stump. Regeneration has occurred, anatomically speaking, but that doesn't mean the patient can actually use their hand again, does it?
Not at all. And this is where we hit the often disappointing reality of nerve repair. We absolutely have to quote Young from 1942 here, it's just so pertinent. But the journey of the axon tip to an end organ is only the most dramatic of the phases in the process of regeneration, and its arrival is alone no guarantee of the return of useful function.
That says it all, really. Just because the wires connect doesn't mean the device works.
Precisely. And it's incredibly common clinically and pathologically. Surgeons often go back to revise a failed nerve repair years later, and under the microscope, they find thousands of regenerated, myelinated axons successfully bridging the gap between the nerve stumps. Figure 1.5.10 shows exactly this. Anatomical regeneration looks great.
But functionally?
Functionally, it's a failure. The patient has no useful movement or sensation. So the big question is why? Why this disconnect between anatomical regeneration and functional recovery?
The sources point towards problems with actually reinnervating the end organs correctly, right? The muscles and the sensory receptors.
Yes, it seems to be a failure at the final destination. 2 main issues. First, muscle failure. Even when motor axons successfully reinnervate muscle fibers, the resulting function is often poor.
Weakness.
Chronic weakness, yes, but also impaired coordination, reduced stamina, increased fatigability. Part of this seems to be a selective failure to regenerate the largest diameter motor axons, the ones responsible for generating maximum force and speed. The smaller ones might get back, but they can't do the heavy lifting.
Okay, so the muscle power isn't fully restored. What about the sensory side? This sounds like where the real miswiring happens.
This is arguably the bigger problem, what the sources call sensory organ blinding. You see, after a clean crush injury, axonotmesis, where the tubes are intact, regeneration is usually quite orderly. Motor fibers tend to find muscle, sensory fibers find sensory receptors.
But after a severe injury, neurotmesis or a repair where things are jumbled.
The reinnervation is much more chaotic and inaccurate. An axon sprout that was originally meant to innervate a muscle spindle, a stretch receptor deep in the muscle might accidentally grow into and connect with a Golgi tendon organ, which senses tension. Or a skin axon meant for light touch might end up innervating a pain receptor or vice versa.
What does that miswiring do functionally, especially in the muscles?
It has devastating consequences for motor control. Think about it. Your brain relies on constant, accurate feedback from those muscle spindles and Golgi tendon organs to know exactly what the muscle is doing, its length, its tension, its rate of change. This proprioceptive feedback is essential for smooth, coordinated movement.
So if the feedback signals are wrong,
if the brain gets signals meant for a spindle but coming from a tendon organ, or no signal at all, or a garbled signal, it can't generate the correct motor commands. The muscles become effectively blind to their own state. This leads directly to clumsiness, poor coordination, and that feeling of weakness, even if the muscle fibers themselves are getting some nerve supply. Remember, muscles aren't just motors, they are sophisticated sensory organs, too.
Right. And what about the sensors in the skin? The touch receptors, pain receptors.
They also suffer. After denervation, these cutaneous receptors slowly degenerate over time. Some might disappear completely after about 3 years if no nerve grows back. Reinnervation can reverse some of these changes if it happens in time.
But the longer the delay, the worse the outcome.
Absolutely. The longer the period of denervation, the less complete the structural recovery of the receptors, and the poorer the quality of the resulting sensation, even if axons do eventually reach them.
Okay, so given all these challenges with getting the right axon to the right place after severe injury, surgeons have turned to other strategies, like nerve transfers.
Exactly. Nerve transfers have become increasingly important. They basically acknowledge that trying to directly repair a badly damaged nerve, especially after a long delay or if there's a large gap, is often functionally futile due to all these problems: scarring, misdirection, and organ failure.
So instead, you borrow a nearby healthy nerve.
You take a healthy, less important donor nerve, or even just a branch of it, cut its proximal end, and surgically connect that end to the distal stump of the critical injured nerve you want to restore function to. A classic example is taking the accessory nerve, which normally just supplies the trapezius muscle in the shoulder neck,
And connecting it to?
connecting it to the distal stump of the suprascapular nerve, which supplies the key rotator cuff muscles needed for shoulder function. You sacrifice some trapezius function to regain shoulder rotation.
And this works because the brain can adapt.
It works remarkably well in many cases, precisely because the central nervous system shows significant plasticity. It can learn to reinterpret the signals. We see clear clinical proof. For instance, transferring part of the ulnar nerve, normally for hand muscles, to the nerve supplying the biceps muscle can allow a patient to regain independent elbow flexion. The brain learns that activating the pathway that used to control the ulnar nerve now needs to activate the biceps.
That adaptability is amazing, and the sources highlighted a really striking difference in this plasticity depending on age, particularly with sensory remapping after transfers.
This is one of the most fascinating findings in the field. It really underscores how adaptable the developing brain is. Let's look at sensory recovery after those severe brachial plexus avulsion injuries in babies or young children.
Okay.
Sometimes surgeons will perform radical transfers, like taking intercostal nerves, the nerves running between the ribs, supplying sensation to the chest wall, and connecting them to the distal stumps of the avulsed brachial plexus nerves that should go to the hand.
So wiring a chest nerve to a hand nerve pathway.
Exactly. Now, in neonates and young children, the results can be astonishing. The sensory recovery is often remarkably good. And follow-up studies, like those shown in figures 1.5.12 and 1.5.13, confirm that when you stimulate the skin of the hand that's been reinnervated by these chest wall nerves,
The child feels it. Where?
the child accurately localizes the sensation to the hand, not the chest wall. Their brain has completely remapped the input. It interprets signals coming through the intercostal nerve pathway as originating from the correct hand dermatomes that were lost. It's a profound example of cortical reorganization.
Wow, so the brain literally rewrites its own body map. But that doesn't happen in adults.
Much, much less effectively when the exact same intercostal to brachial plexus transfer is done in an adult.
What do they feel when you touch the reinnervated hand skin?
Usually they report feeling the sensation back on their chest wall where the intercostal nerve originally came from. The sensory input is referred back to the donor site. Only rarely do adults manage to correctly localize the sensation to the hand.
Why the difference?
It indicates that the mature adult brain has much less capacity for this kind of large-scale sensory remapping compared to the highly plastic developing brain of a child. That window for profound sensory plasticity seems to largely close after childhood. The wiring becomes much more fixed.
Okay, let's try and bring all these complex factors together. What are the ultimate things that really limit the chances of getting a worthwhile functional recovery after a peripheral nerve injury?
Several key factors stand out consistently. First, the sheer violence of the initial injury and the extent of associated tissue damage are huge predictors. High-energy trauma is always worse.
And damage to blood vessels is critical.
Absolutely critical. Associated vascular injury leading to ischemia is profoundly deleterious. If you don't ensure adequate tissue perfusion, you can pretty much rule out any chance of worthwhile recovery, no matter how good the nerve repair is.
We keep coming back to time.
Time. Delay before repair is arguably the most consistently negative factor, especially chronic delay. We've seen why. It leads to that progressive fibrosis and shrinkage of the distal stump, making accurate surgical connection impossible. It leads to the death of Schwann cells and loss of trophic support.
And that leads to the target organs failing.
Yes. Chronic delay allows irreversible atrophy and destruction of the target tissues. The muscle fibers waste away. The muscle spindles and skin receptors degenerate and disappear. Even if you get perfect axon regeneration later, there's nothing functional left for them to connect to.
And finally, age itself plays a role.
Chronological age definitely impacts outcomes, particularly sensory recovery, likely due to that reduced central plasticity we just discussed, but maybe also due to age-related changes in the molecular signaling pathways involved in regeneration and reinnervation at the peripheral level too. Older individuals generally have poorer outcomes than younger ones for equivalent injuries.
It really is a complex interplay. What stands out to me is how clearly that line between just the axon breaking axonotmesis versus the whole support structure breaking neurotmesis defines the potential for recovery. One might heal on its own, the other absolutely needs intervention.
That's the core structural lesson, yes. Axon versus scaffold.
And this concept that a lesion isn't static, that it can actively deepen over time because of ongoing pressure or ischemia, turning a potentially recoverable axonotmesis into an unrecoverable neurotmesis. That really drives home why time is so critical, why getting the pressure off, restoring blood flow is job number one.
Couldn't agree more. We've seen nerve trauma isn't just some localized damage, it's a full system crisis. It involves potential death of neurons back in the CNS, a highly orchestrated but time-limited cleanup and preparation process in the distal periphery, and a desperate race by the proximal axon to grow back before that partial pathway collapses or the target organs die.
And the fate of that whole process seems to hinge, moment by moment, on what those supporting Schwann cells are doing and how quickly intervention happens if needed.
They really are the unsung heroes, or perhaps the crucial weak link, if things go wrong, in the peripheral nerve story.
So, reflecting on all this, we saw how nerve transfers can leverage the brain's inherent plasticity, especially in children, allowing something as radical as rewiring a chest nerve to feel like a hand nerve. If the brain is capable of that level of reorganization in response to surgery, it makes you wonder, what non-surgical approaches might tap into that same potential? Could we use intensive sensory retraining, maybe targeted brain stimulation, or even develop drugs that could recreate that supportive acute Schwann cell environment in chronically injured adults? Could we find ways to boost that amazing age-dependent plasticity to improve sensory remapping and functional recovery long after the initial injury?
That's the million-dollar question, isn't it? How to reactivate or enhance plasticity in the adult system.
Something for you all to think about until our next deep dive.